Hi, welcome to my Eye to Eye podcast, and I'm happy to have my next guest, Professor Dr. Renato Ambrósio from Brazil.
Good.
Hello, good morning. Thank you so much for joining.
My pleasure. My pleasure.
Let's start with the introduction. I don't know how to call now because my first question was like how the idea of creating a new Keratoconus, I will not say subspecialty, I would say branch,
Yeah.
was
Well,
born.
Dr. Tutsi, it's a pleasure to be here with you. Your question is very interesting because when you think about a subspecialty, it's not even a subspecialty, it should be a super specialty. I think keratoconus and corneal ectasia should be considered a new branch for us to dedicate time and to study more and to devote to our patients because we first have a lot of patients. The number of patients with keratoconus and corneal ectasia, they are increasing every day at the clinics around the world. And we have also developed many things to improve the care for those patients. Interestingly, refractive surgery is related to all these developments. And there are many paradoxes related to the evolution in keratoconus because we broke paradigms. When I did my fellowship, for example, about 20 years ago, we only had the penetrating keratoplasty to treat patients with advanced keratoconus. We only had rigid gas permanent contact lenses to treat for visual rehabilitation. And a lot of people would say that visual rehabilitation would benefit for the contact lenses, which I highly agree. There is absolutely no question about it. But some contact lens specialists would even say that contact lens would halt the progression of ectasia, which is not the case. I would say, unfortunately. So we developed a lot of knowledge about this, and this is related to refractive surgery because refractive surgery boosted the evolution in many fields of ophthalmology, considering basic science, wound healing response, corneal imaging, lasers, pharmacology, and the development of many techniques were uh, probably implemented in the keratoconus treatment and also corneal pathology. And keratoconus, among corneal pathologists, probably the one field that really was impacted by this evolution.
The next question is I didn't put it in the list. It's today when I was thinking, it just came out, and I did not know how exactly to formulate the questions, but it helped me to define it because it's a bit complicated. So, what is the fundamental point of combining keratoconus with refractive surgeries? Is it only about the visual acuity, or is it also about reshaping the shape of the cornea in order to create like kind of balanced morphology? So
Great question. I think refractive surgery should be a new specialty medicine. That's the case. We have the pioneer work by colleagues, professors from 25, 30, 50 years ago that started uh, some new procedures that would be very controversial to
mhm.
reshape the cornea to improve vision without glasses and contact lenses. Probably that time contact lenses were even not available. We need to have standards for quality. We need to have standards for the excellence that we can provide on refractive surgery. Refractive surgery is an elective procedure, and we have to distinguish the elective procedure from therapeutic procedures. Therapeutic procedures using refractive surgery technology. So the concept of therapeutic refractive surgery should be considered, and that's perfectly implemented for keratoconus and corneal ectasia. Um, when you think about the need for a specialty, is a need for recognizing the evolution, the need for you to dedicate your time and to study to provide the best quality of care for your patients. We have a lot of technologies, we have a lot of techniques, we have a lot of knowledge that you should have so that you can become a true specialist. And of course, refractive surgery will be a specialty medicine in which ophthalmology is a absolute prerequisite. You have to go through ophthalmology training for becoming a refractive surgeon. But if you need to become a refractive surgeon, if you want to do that, you need to go for specialty training beyond ophthalmology, beyond but not over. That's a very nice concept that I learned from Dr. Brad Rundeman, who is the editor of the Journal of Refractive Surgery, and we wrote an editorial about ectasia risk screening, what we were screening for, and we wrote that about 10 years ago as well.
So basically, keratoconus and refractive surgery is not about the visual acuity, it's also about the reshaping the cornea.
Let me explain to you why we need to distinguish refractive surgery as an elective procedure and therapeutic refractive surgery. I saw one of the patients I saw yesterday at my clinic here in Rio de Janeiro. It was a patient that had a corneal ring. He has -3, -2 with 20/25 +1 visual acuity, distance corrected visual acuity. This is a great result for a patient that had moderate to advanced keratoconus and was considering needing a keratoplasty. If I have the same result on a patient that had LASIK, SMILE, or PRK, that's a disaster. And so we need to distinguish, because otherwise we won't be able to understand what is success. And of course, we need to distinguish that in our minds, and we need to educate the patients about expectations. A lot of people that visit me, I ask this very simple question: what's the goal of refractive surgery? And they say, oh, is to have a patient with 20/20 plus, 20/15, 20/10. I was training in refractive surgery when we get the 20/10 by 20/10. And it was by the end of the last century. I'm not that old, but I trained in the late 90s. And this Catch the Wave, it was an ISRS program, very nice program, very good education program from the International Society of Refractive Surgery, that we were talking about the excimer laser connected to the wavefront devices, the diagnostic device. So we have sharing device, we have Hartmann check device, we have ray tracing device. Many different devices were introduced to create a better understanding of the optics of the eye. And from this, we would be able to create a better vision, the supervision. And the militaries were looking at supervision with super soldiers and things like that. And we are talking about having 20/10 by 20/10. And I remember in a talk I gave, it was, I think, in the ESCRS, I said, probably we would have 20/30 by 20/30, but 20/20, even 20/20 by 20/20 wouldn't be possible. 20/10 by 20/10 would be like a super big dream. It was like hyper optimistic. And the point is that visual acuity is not the key. It was visual quality. And beyond visual quality is quality of vision and quality of life. And patient satisfaction is the key. So if you ask me, what is the goal of refractive surgery? It's to improve patients' life. And they would live more comfortably with freedom from devices for glasses and contact lenses. And they would be satisfied with the quality of vision as well. Because we have some patients that are not happy with 20/15 uncorrected distance visual acuity. And the quality of vision is very important. We have patients that are with good quality of vision, but they have dry eyes. And if they never understood they had dry eyes before, they would not be happy. So patient education is very important consideration. And patient expectations will come from patient education. So patients should be aware about that. So refractive surgery has a tremendous impact on vision of the patient and the life of the patient, the quality of life of the patient. And if you set proper expectations, the success will be much higher. And success is the patient to be happy at the end of the day.
Yeah, so basically it's everything about individualized approach to a patient. So the gold standard for keratoconus is a cross-linking, and there are many protocols of combining cross-linking with refractive surgeries. And with regards to all protocols of refractive surgeries with cross-linking, which is your favorite, or which do you think is the safest? Or maybe this is a bit not
That's
right
the
to
point.
ask like that.
They're different animals. The cat
Mm-hmm.
and the lion. 95% of the genes is the same. But if you go to pet a lion like you do with a cat, you're probably in big trouble. Also, you don't want to pet be avoiding a cat like it's a big lion. It's not good. So you need to understand. And metaphors apart, actually, I like my metaphors. It's important to understand the difference. And
Mm-hmm.
even though they are very similar, they're not the same. Refractive surgery as an elective procedure should be very different than therapeutic refractive procedures that we use refractive surgery technologies to treat patients with keratoconus. Having said that, there are some cases that we are in between. Those are the mild keratoconus, susceptible keratoconus, fruit keratoconus, and the nomenclature for that is is still controversial. We don't have a consensus on that, but those elective procedures on patients like this. So, just to summarize, keratoconus is a disease. The treatment for keratoconus has two goals: rehabilitate vision, which is something we learned since residency in ophthalmology, and halting the progression of the disease, which was introduced recently by Professor Silas' group with the cross-linking. Those are different goals, and we
Mm-hmm.
have to understand each of the individualized medicine is related to having corneal imaging, and corneal imaging is not alone. You have to start with the basics. You have to start with anamnesis, asking the patient how you're doing, your history, your family history, what treatments you have done, what is bothering you, how can I help you? That's where you start. We don't go for topography, tomography, wavefront devices, biomechanical measurements, all this genetics. All this
Mm-hmm.
information is going to be considered in face of what the patient needs. And you have to be clear in your mind that the goal for keratoconus is rehabilitate vision and halting the progression of ectasia. I think that halting the progression of ectasia is as much important as halting and as improving vision and rehabilitating vision. And there is a concept of losing opportunity. Losing opportunity. If you have a progressive keratoconus, keratoconus is a progressive disease, but not every keratoconus is progressing, because
Mm-hmm.
eventually not every keratoconus is a keratoconus. Some of them are
Okay.
only some of them are only ectatic diseases. My understanding about this, I don't want to confuse you because it's a very complex but simple concept. Every keratoconus is a ectasia. Keratoconus is a kind of a genetic disease, which are we are not still ready to diagnose, but we detect based on shape of the cornea, based on the slit lamp examination, based on everything, the patients with keratoconus. But some of these cases are secondary ectasia due to eye rubbing. And I
Yeah.
highly agree with my colleague and friend Damian Gatinel campaign that eye rubbing is very bad for the patient, but I may not consider a sine qua non because some corneas are very weak and those corneas would progress despite of mild or no eye rubbing. And if you stop eye rubbing, of course, you improve your keratoconus treatment. And eye rubbing, telling people to not to rub the eye is very simple, and we should promote that as much as possible. That's one of the main things of our Violet June campaign. And but every cornea surgeon will learn if they really listen to the sentence. Eye rubbing aggravate keratoconus and may even cause ectasia. I will repeat.
Okay.
Eye rubbing aggravates keratoconus and may even cause ectasia.
Without predisposing factors.
Yes, you can start with a 650 thickness cornea, perfect
Okay.
endothelium, very strong cornea. And if you rub that cornea too much, eventually you break the point in which biomechanical uh,
Mm-hmm.
failure would occur, and then you have a progression. This is the second hit hypothesis, the two hit hypothesis. The first hit is eventually the genetics predisposition, and the second hit is going to be the environment. And we have a very nice editorial by Professor McGee, who really put this together. And we have the cycle of decompensation for biomechanics from Cynthia Roberts and BJ Dupes. And I talk about this in my papers and talks every time. So, and I think it's important that we distinguish progressive keratoconus and progressive ectasia, because prognosis is going to be different.
But in terms of the management, it would be the same
No.
for ectasia and keratoconus.
Basically, in this clinical settings, it can be the same, but the prognosis is different. Uh, for example, when you do any examination like a topography, placido disc based topography or a Scheinflug based tomography, you have to ask a question to the exam. Of course, you do that as part of a routine, but when you look at the exam, you should be in your mind thinking, what is my question? Which information is important here for me to use that information for making a better clinical decision to help my patient? And we have screening, confirming the diagnosis, setting the staging of the disease, if it's mild, moderate, advanced, the staging of the disease, which is different than the classification. We have different ectatic diseases. Classically, we have since Bellin, Krashmer, and Feathers, 80s paper, which is the thinning disorders, which is keratoconus, pellucid, and keratoglobus. Those are the three thinning primary disorders that we have. And I would say primary ectatic disorders because those are kind of dystrophic disorders of the cornea. And we have the thinning pattern distinguishing what is true pellucid, what is keratoconus. And if you have more knowledge on the shape, you can have like inferior keratoconus with a pellucid-like shape on topography. And keratoglobus is a much less common, much more rare situation, but we see a handful of patients like this as well. And eventually you have patients with keratoconus and pellucid at the same cornea. This is published in, there's a Japanese paper in the 80s about that. And I have a few patients that we saw even recently. And with OCT and Scheinflug, we can get a lot of information about that. And but having this situation, we have also corneal ectasia. And so we have classification and we have the prognosis. Prognosis is very important. We have the follow-up because progression is important. So the susceptibility, the likelihood of progression is important, and confirming the progression is very important. And you want to be very sensitive for that and also very specific. So you want to be sensitive to detect very mild changes that would say this patient needs cross-linking. And the paradox is if you don't need, you should not do. But if you need, you should do it right away. And I say that to my patients every day because patients with keratoconus are very interesting because they come with families. They come with father, mother, grandmother, uncle, brother, older brother, everybody. They don't have space in the room many times.
And everybody needs explanation.
And everybody needs explanation. That's why I wrote my book. I have keratoconus and what? So I'm happy that this interview takes the opportunity for me to talk about the Violet June campaign. So I started the Violet June campaign 5 or 6 years ago here in Rio de Janeiro because there was a patient. I used to practice jiu-jitsu here, Brazilian jiu-jitsu, Gracie jiu-jitsu, and one of my friends from when I was a teenager, he called me and he said that one of his young athletes was getting blind because his retina was dissolving and getting too thin. And I remember listening to his audio and talking to my wife. I'm sure this guy has a keratoconus and this is not a retina problem because a lot of people confuse retina and cornea. And that was the case. And the young guy was a very athletic guy, very nice guy. And one doctor told him that he could not do martial arts anymore because of the keratoconus. And then he talked to the parents. I will get blind, but I will keep my practice. And then you start a huge situation. And I asked, did the doctor say to you that you cannot rub the eye? No. He said, I cannot do my martial arts anymore. And I said, You see, the lack of information and the misinformation is even worse than
Yeah.
the disease. That's
Yeah.
exactly what we say in our campaign. The lack of information, the misinformation, may be even worse than the disease itself. So the guy is like a young adult now, and he is still practicing jiu-jitsu and with good vision with a scleral lens after cross-linking. And in that case, he needed cross-linking right away, and he had the cross-linking right away. So if you need cross-linking, you should do it as soon as possible. But if you
Mm-hmm.
don't need, eventually doing it may be too much. And then that's when you
Mm-hmm.
have more chances for complications. There was a very nice in the Journal of Cataract and Refractive Surgery, the JCRS, in March 2021. There was a case, one of this case consultation series that I wrote one of the commentaries. That was a patient that had surgery, I think, in the Netherlands, and had cross-linking only one eye. So one eye had cross-linking and had a scar, and that scar was in the middle, in the center of the cornea, and very deep. And that scar was preventing the patient even to have good vision with a rigid gas perm contact lenses.
Mm-hmm.
The fellow eye of the patient was 2015 uncorrected, and I was able to add the pentacam data from that eye that was never treated. And there's no keratoconus in that eye. The Bell Ambrósio is normal. The pentacam randomophorus is normal. The shape of the cornea is normal. The patient has 2015 uncorrected vision. So based on that eye, I can say the other eye did not have keratoconus. Maybe the
Yeah.
patient had a scar, an ectasia, or something. I don't have a pre-cross linking in the eye. And I put in my commentary that Professor Seiler and his group are to be commended with a Nobel Award for the developing of cross-linking procedures. Nevertheless, cross-linking is not for everyone. Today we have the vaccine came to be very popular for people because we should vaccinate everybody. And I agree, we should vaccinate everybody once we have safety levels. And I had my 3 shots of COVID, by the way. But I think that the medicine and the poison, they are very similar. You know what is the difference between the medicine and the poison?
No.
I have a bottle of water here. This can be
Yeah.
medicine and poison. The difference between medicine and poison is first the dose. The
Uh-huh.
dose will change from medicine and poison, and can be with anything. And then I started elaborating a little more about that because not only the same dose of the same substance can be medicine and poison. For example, if you
Yeah.
have a patient with diabetes, this
Yeah.
patient with diabetes, the same glucose, hypertonic glucose that you can inject in his vein can be medicine and poison. I can give you 2 scenarios. First, he took too much insulin, so his glucose levels is
Yeah.
too low. He is down, he is very, very lethargic. If you put his glucose in his vein, he will be up. The same
Mm-hmm.
dose, nevertheless. If he didn't have his insulin, his glucose levels is too high, you can just put him in a coma. So the same dose with the same substance can be medicine or poison, depending on when you do it. So
Oh.
how much,
Mm-hmm.
when. And talking to the residents is very, very, very good because it 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 really nourishes me on the learning experience because the best way to learn anything is to teach. So I was asking about that with my residents about 2 years ago, and one of the residents, I don't know, he was really thinking about that, but he said the administration, if you put like oral, if you put in the vein, can be, and I
Mm-hmm.
said, I don't know if you're just trying to get something, but you just opened my mind to something. You just taught me something because cross-linking procedures. What we do is to sometimes we don't remove now the epithelium because we put riboflavin on the cornea and then we irradiate. And great work by Professor Hafezi from Switzerland. He put together also the oxygen. So we need oxygen, UV light, and riboflavin so that we have the cross-linking effect is about is a photochemistry of that is very complex, but very nicely understood today. So, what if we give people oral riboflavin
Yeah,
so that
there
they
is
go
another
with the
protocol
sun?
of that too. Yeah.
So we started using that. So the administration through is another possibility. So maybe that patient in the JCRS, he didn't need a cross-linking procedure with the Dresden protocol, but if he had like oral riboflavin, could be enough. I don't have the data from that case, but what I see probably that case even is not even an ectatic disease. It's a similar shape that can resemble an ectasia, and a lot of people would say, "Oh, this is a red topography. You need cross-link,"
Hmm.
which is unfortunately confused. So, if you want to do it, you need to have proper documentation for better understanding of the patient and setting a treatment protocol for improving the patient's life as much as possible.
And I think this oral administration would be only for countries who really have sunny weathers.
Well,
Or
there's a
or-
nice device from Japan that they have glasses and they have some lights that can
Mhm.
irradiate UV. So it
Oh.
can be, and you can have an UV source at your room. You just put in your room. So we have a lot of going around the sun. Of course, in Rio de Janeiro in Brazil, we have a lot of sun through the year. Now we are finishing our winter time and it's still warm. Uh, we have mild. Uh, the temperature is great, but
Lucky you.
lucky us,
We
yeah.
don't have it
Well,
that
we
much.
have different problems. We have different problems. But
Yeah.
going back to your protocols, I think it's always a good opportunity to remember the protocols. We have the Dresden protocol, EPI-OFF, which is
Hmm.
3 milliwatts, 30 minutes, and I started doing that in 2008, and it was really really long time. And it's a good opportunity because you talk to the patient and you start learning about the patient a lot. And I still remember the conversations I had with some of these patients. And the dressing the 30 minutes protocol is the best way to increase the cross linking. But again, going back to the basics of poison and medicine, the dose is a problem. So too
Hmm.
much cross linking induced may be not good for many patients. So, if you look at the in vitro, in vivo studies in the lab, the Dresden protocol still creates more cross-linking than any other procedure. But if you use the Roscoe-Boscoe reciprocity,
Hmm.
you can go down to even seconds, but it will be no cross-linking at all because there was no time for the you have the energy, the dose, but so I think the sweet spot is around 9 milliwatts per 10 minutes. That's
Hmm.
probably the sweet spot. That's what I'm doing today. And we can combine that with the excimer laser. And that's a different story because, again, you can combine that with just a PTK and you can do custom shape, topography guided, tomography guided, wavefront guided ablations. And again, you go back to the philosophy, the basic philosophy of what you're trying to achieve. You're trying to achieve emetropia, or you're trying to achieve stabilization and regularization. And those are two different animals. That's why I say you have
Yeah.
to understand exactly what you're talking, because it's the same thing. You just have the same expo laser, the same diagnostic protocols, and but they are not the same. The goal is not the same. So the level of tissue removal that you have to be very conservative on this. And we have the protocols, and I think all of them are Athens protocols modified. John Canelopoulos
Hmm.
was one
Yeah.
of the first ones to develop this, and his procedure was a PTK, and then a 50 micron topo guided, and could be placido shape or Scheinflug shape derived topo guided ablation with a 50 micron. So that's what he taught me, and in that time we were still using 3 milliwatts per 30 minutes. Now we have different doses for even reducing from 5.4 joules, uh,
Hmm.
less joules, maybe even more beneficial. Again, going back to the understanding. But It's not a refractive procedure. The goal of this procedure is to improve distance correct vision. And a lot
Yes.
of people ask, what's the difference between therapeutic and elective refractive surgery? One is to aiming for uncorrected vision, the other is aiming for distance corrected vision. That's the most simple way to define. There's more on that, but if you get this in your mind that one you want to have a close to planar refraction, the other one you want to have a distance corrected vision that can be correctable with spherical cylindrical lenses. And not needing a transplant is a success. Not needing gas perm contact lens is a very big success, because if you have a good cylindrical sphere cylindrical shape correction, you can get a benefit for the phakic IOLs, which is the bioptics, the concept of therapeutic bioptics. The bioptics is a procedure for extreme myopia that Zaldivar was considering a corneal procedure, like a LASIK procedure, and then putting a phakic IOL. And we have with posterior chamber, with anterior chamber, Aliot, Gale, many of them describe with the anterior chamber IOLs as well. But this is different than when you have a therapeutic refractive procedure with a bioptics approach, in which you can even combine a corneal procedure, like when I put a ring and then you do a cataract surgery. The order make a change. Uh,
Mm-hmm.
I prefer to do the ring first in some cases, and sometimes I prefer to do the cataract surgery in some cases. And eventually, there is no way of creating one formula that will fit for everyone. So it's like I said in the beginning, it's individualized. We need individualized approaches.
Do you think we already decoded the behavior of the cornea after cross-linking and refractive surgery combined? Or we
Well,
are at the beginning, or we are in the middle, or we are still in the learning curve?
we will be always learning. It's the paradox of optimization and perfectionism is related that we should aim for perfection, but we should
Mm-hmm.
be aware that we will never achieve. And being an optimalist is like you have to try to be optimal every time and to improve a little bit every day. And refractive surgery did boost the knowledge tremendously. And I was very fortunate to do my fellowship with Steve Wilson. And when I was in Seattle, Washington in the early 2000s, he was searching for a magic bullet for treating the corneal haze, the corneal scar that would come after high diopters PRK. So we had a big study that we treated the white bunny rabbits and the New Zealand beautiful rabbits, and I did surgery so many of them, and we learned a lot from the wound healing response. So we know we have
Mm-hmm.
apoptosis, we have cell infiltration, then you have myofibroblast transformation, but we didn't have a way to block this. And interestingly, he developed many studies and he looked at how to block the TGF beta. And he discovered that losartan, which is a common hypertensive that he was taking in his cabinet, was the response. And I saw his Bahakir lecture last year, and he talked about losartan, and I saw a patient 2 days later, and I said we can treat you. And this patient had a complicated LASIK procedure and developed haze. She had a thin flap LASIK with a colleague, and then she had striae. Colleague lift the flap, scrape the epithelium, and the patient developed a severe haze.
Mm-hmm.
And that patient was really benefited by the losartan topical drops. I had a topical losartan done by a colleague here, a professor of pharmacology. He has a company, and he was very keen to ask for the how to prepare the losartan based on Wilson's experience in the rabbits. And we treated, that was the first patient treated. So we have now a treatment for corneal haze, and we have colleagues from other places now doing this multicentric. We should be careful to combine this data and to
Mm-hmm.
really publish scientifically. But so we learn a lot. So and we always learn. When you talk about the the behavior of the cornea, there are two responses. First is the wound healing response,
Yeah.
and second, which is the biomechanical response. So biomechanical response, we are also learning. And I remember when I was finishing my fellowship, I was at the academy in 2002, and I met David Luce, PhD, and he was the scientific from Riker, and he was with a prototype of the ocular response analyzer, and he was at the floor at the academy getting people to get the ARPUF in the eyes because he was doing his study there. He was doing the the demographics of corneal hysteresis there, and he was explaining to me that with his machine he was able to compensate the true pressure of the eye. And and he asked me, young man, what you doing, what is your field? And I said, I just finished a fellowship in refractive surgery and going back to Brazil. Oh, you need this machine because it will correct the IOP that you measure in your patient. And I said, well, that's very interesting how you do that. And he was explaining me about the behavior of the cornea, and honestly I didn't understand everything he was explaining me, but actually, I even wouldn't agree that the cornea does like this. I had a hard time to really see the cornea getting, with a deformation so big.
Applanated that
Yeah,
way. Yeah.
applanation is fine, but I wouldn't say. And I remember when we get some cameras to see that, I was, oh, that's exactly what he was saying. And today with the Corvus, which is a machine that was developed after that, but I remember saying to him exactly this. Well, I don't care much about the IOP, but I care on how you correct the IOP. Because if you can correct the IOP based on the cornea structure, that measurement is important for every refractive surgeon, because it will be the question we are asking if you can do LASIK or not to prevent ectasia. Because you're not, and that's the basic. I mentioned the editorial with Brad Rundeman, what we are screening for, and the word beyond but not over came really about that, because we are not screening for keratoconus. When you do your LASIK consultation, you are thinking, does this patient has keratoconus or not? Of course, if the patient has keratoconus and you weaken the cornea further, he will have a progressive keratoconus. But your question is, does the patient can afford it? Can the patient afford the weakening of the laser vision correction procedure so that he'll be stable? So we'll go from detecting mild keratoconus to understanding ectasia susceptibility, which is something that any cornea may develop. It's like the second hit. The second hit for one patient will be like too much dry rubbing that you break the decompensation cycle for ectasia, or some patients with just a little PRK, you can be making that cornea unstable. So
Hmm.
uh, the biomechanical understanding of the cornea is very important. So we started using the ocular response analyzer, and then with the Pentacam, and then the Oculus R&D, they look at that idea of shine fluke, and we have like a logo of the study group we have in Rio. We have the ocular response analyzer with the shine fluke image in the back. And in 2009, they showed me the dynamic response Corvus, which is a ultra high speed shine fluke camera that you monitor in 31 milliseconds, 140 frames. So you can see the cornea deforming. And based on that information, you can derive a lot of understanding about corneal shape. And again, we have too much information, and our brains are not enough capable to process all this multidimensional data. So we have artificial intelligence for learning with machine learning, and we have to train the machine learning to get an answer so that it can be implemented in the clinical setting. And that's a very, very nice topic to study, because we have a lot of data, and we have to ask proper questions to that data so that we use the data properly to make a clinical decision. And the algorithm that I created is artificial intelligence applied square. So it's AI square squared, AI2 squared. So which is
Hmm.
artificial intelligence applied and also ancient intelligence applied. Ancient intelligence is the philosophy, the whys. Why you're doing
Yes.
this? So you diagnose, prognose, see the progression, see the treatment. All these phases of diagnostic should be understood by you when you see any topography, and the data should be analyzed with this in your mind.
So this, I think now you talked and explained everything so perfectly, and partially, or maybe even fully, covered my next questions when I wanted to ask, what is your why and how, as a refractive surgeon in keratoconus cases, who wants to achieve and optimize the best outcomes? So I think you covered that
But I
already.
think it's interesting to highlight that refractive surgery, elective and therapeutic, should be distinguished by the doctor. But
Mhm,
we have some patients in between. I had a patient, for example, that she was a physiotherapist and she came with intolerance for contact lenses, and she came with intolerance also for glasses.
mhm,
So she needed help, and she was 20/25 minus distance corrected, and she
mhm,
needed help. And based on the cornea structure, I said, you can do a custom surface ablation, but you need to understand you cannot rub your eye, and you have to come back so that we will evaluate if you need cross linking or not. I don't agree, unfortunately, I would say, because probably my clinic will do more procedures, but I don't agree with the prophylactic cross linking. Actually, I don't agree with the prophylactic cross linking using the epi-off protocols that
mhm,
we have, because the chances of a scar is much worse. I saw many patients with like a Athens protocol as a refractive procedure in patients with thin or weak corneas, and they do the Athens protocol just for using the cross linking as a little plus, even the concept of plus. And we know that we talk about that in the past. The plus, the cross linking as a plus, I don't think is the best strategy. But we need to think that some of these patients, they may benefit from PRK, from surface ablation, custom surface ablation for patients with mild keratoconus. And we have some experience that collects back to the 90s, and many patients, they do well, because eventually some of these patients, they don't have true keratoconus, they have more secondary ectasias, and we
mhm.
don't have genetic diagnostics yet. I do
Yeah.
believe we will have when we talk about multimodal information, it comes from uh, anamnesis, corneal imaging, topography, tomography, biomechanics, wavefront, axial length, corneal cells, all this data together. And then we have molecular biology and genetics. And I see that one day we'll see that if the patient has more allergy, inflammation in the tears and the genes, and we have work by my colleague uh, Harji Shetty from India, that he is very advanced on all of this understanding on on locks, on metalloproteinases, on advanced imaging, along with molecular biology, that will say now this patient has more ectasia and more predisposition. Because I
Mhm.
had, it will be one or the other, and it's like a continuum. Ectasia susceptibility is a continuum, and that's what we try to achieve with the integration of multimodal imaging. Today we have tomography and biomechanics, Pentacam and Corvus, that we integrate with the TBI, and we have now a TBI V2 that I hope to have it published in the American Journal of Ophthalmology. It's submitted, it's under final revisions, and one of the things is that we have the very asymmetric ectasia cases, one eye with uh, unquestionable ectasia, and the fellow eye with a normal topography, normal vision, normal topography. And some of these normal topographies are not so normal, because you see in a few patients some irregularities on corneal shape. If you change the scale, it gets very obvious. But those patients are mild because they have good vision and etc. And those cases are the ones that we use to learn, because they have they are from the patient with very symmetric. And the term unilateral keratoconus is wrong, but
Mhm.
unilateral ectasia is correct. So we have ectasia can occur in any eye, and it can occur due a secondary mechanism in any eye, and in some patients only in one eye because they've only rubbed one eye and that's it. We are
Also
learning
without
also,
factors, basically.
yes, the secondary
Mhm.
factors. So we
Mhm.
need to understand why you're doing surgery. If you're doing elective surgery or doing therapeutic surgery, and in some cases you have in between. And that patient, that the physiotherapist, she came back 1 year after surgery, and she surprised me with her question because she was in the medical field, and she asked, "Doctor, I'm doing well, and I'm here just to ask you if I need cross linking." And I said, "What?" "Yes, you told me I know I cannot rub my eye, and I should be coming back here to check if I need cross link." And I said, "Yes, I said that, and thank you for listening and for learning, and let's see." And she was very stable, and she's probably 6 or 7 years out of surgery today, and she's doing still well. So cross linking is not needed, but when it's
Mhm.
needed, it should be done as soon as possible. It's not needed by every patient, but when you need, you should do it as soon, because you don't want to lose the opportunity, because once you progress, the cross-linking effect to regress is very mild, unless you combine with other procedures. And I do a lot of corneal rings. Corneal rings is for reshaping the cornea. And
Mhm.
in the
Yeah.
book, in the Keratoconus, I have Keratoconus and what? That's the title of the book. I have this explanation. Imagine a car that is going down the, the pathway. If you have two movements, you can have a brake or you can go backwards. The cross-linking procedure is having a brake, is stopping the decline, but the ring is to rehabilitate. And sometimes the ring would not be enough. You need ring, and then later you do cross-linking, eventually with the Athens protocol modified procedure for improving the regularization. But you have to be keen on seeing the ring with the OCT and the corneal tissue on the top of the ring, so that you don't have ring exposure, because that's one of the complications we may have. So you have a paradox. If you should do it, you should do it soon as, if you need it, you should do it as soon as possible. But if you don't need it, you should not be doing it.
About Corvis, I just want to ask you something because during my fellowship in Japan, I worked a lot with the data from Corvis, and I was lucky to have a project with Cynthia Roberts too. And do you think that the artificial intelligence can bring, because there are so many parameters there, and can bring just one or two magic parameters which can out of all the during the measurements, like out of all these calculations, and say and tell us the answer if there is ectasia or if there is some
Well,
factors.
we are working on that. Actually,
Mhm.
I do believe, I would say yes and no. Yes, we artificial intelligence will help us better diagnose everything, better use the data for helping the patient on clinical decision making. But I would say no. You should not be only looking at that. When we have the TBI display, the Ambrosio, Roberts, and Vinciguerra display, which integrates the Corvus and the Pentacam, I look at the SPA1. SPA1 is the stiffness at first applanation. This is a
Mhm.
parameter that Cynthia Roberts, PhD, and she's a great friend, and I learned tremendously with her since I was a resident. And interestingly, the SPA1 is the parameter that I look first, and then I start doing my vision on the all the map. But SPA1, you have the histograms, and I remember when I talked to the R&D of Oculus, we need to put the histograms there because, and they would say, "Oh, this is good for engineers, doctors, they don't like it." But I think it's very popular now, and they agree now that we have the green and the red, and you see where the patient is. But one parameter is not going to be the only thing you need. You need to have the data combined with everything. So what the TBI does, and then we
Mhm.
have the CBI. CBI is a linear regression formula that looked at the Corvus data. This is published by Ricardo Vinciguer, and he got the Troutman Award from the ISRS a few years ago. Interestingly, the CBI and the bad D are very highlighted, but they are not going to be adding together for the TBI. The TBI is much more complex. The TBI uses artificial intelligence, and artificial intelligence is now we have this is the paradigm shift that we need to go through, because accepting AI was something that people were open for that, and now people are really closed for that, because it's like a black box. You put all the
Mhm.
data in a black box and then it comes a result, and you don't understand what the black box is doing. Even you can go, okay, let's we use random forest. Random forest is like many decision trees that they are combined. You can go through every decision tree, but you have hundreds of decision trees, and you can get really lost looking at those
Mhm.
decision trees, because in a decision tree is already complex. Imagine 100 or
Yeah.
hundreds of those, and you have a decision, you have a making, but this is your duty as a doctor. That's probably the most powerful lesson that I can give you. Artificial intelligence is going to help us, not replace us.
Yes, this I like this
It's
quote too.
to help us. And your role as a doctor is even more relevant, because you need to know more. You need to have more understanding of the patient. You have more empathy. You need to have your human skills
Component. Yeah. Hmm.
for the treatment of the patient even more pronounced once you have the AI, because AI sometimes will give you you need to be a doctor, and we face many situations, and sometimes I have a TBI of one in a patient that I think I can do PRK in this patient, I can do a fake IOL in this patient, and I even use that data to talk to this patient. You see, this is the algorithm that detects ectasia. Your cornea is weak, you cannot rub your eye. The technology gives you information that you can explain to the patient. Through that information, he may,
Hmm.
okay, now I can understand that, cannot rub my eye. And there's a good video from Arthur Cummings telling people to rub against the caruncle. Very nice. You rub against the caruncle
Hmm.
instead of rubbing against the eyeball, and
Yeah,
that's
you
very
also mentioned
beneficial.
in one of your
Yeah,
articles. So, yeah.
yeah, and some of I saw a patient this week, and he said, I told him, you can call me Doctor Caruncle if you like, but don't rub your eye. He was a 11, 9, 10 years old little boy, and he was rubbing the eye aggressively when he came to the with his mother, his father, everybody. And interestingly, this kid has a twin, and his
Mm.
twin has mild in both eyes. So you would say
Wow.
like a foam fruit in both eyes. And the second twin does not rub the eye. And we even have another set of twin sisters that we published in the International Journal of Keratoconus ectatic disease. It's there. I'll give you this link as well.
Please, please, thank you. So basically, about artificial intelligence, as you gave a metaphor with black box, we should not also put too much information there, because some information can be also lost there. Can we
Yeah,
also say like that?
it's always garbage in, garbage out. We need repeatability, reproducibility of the data. So we need
Hmm.
data that makes sense, because sometimes, and once you have like a large population, like thousands of patients, the feature selection do a good job for selecting the good features. So that's what you're trying to achieve. Sometimes you have some algorithms that you want to make one parameter there. Oh, I like
Hmm.
back elevation. Oh, but the feature selection is going to select which features I like. Asphericity. It has to make sense for the data. And when you do artificial intelligence studies, you have label and unlabeled studies. Label studies will say this is a population zero, no disease. Population one, this disease. But sometimes you have a population there, and before you do the label, you just ask them to do unsupervised learning, and you can get some interesting clusters of data, combining parameters to have groups of patients, and this can teach you something, and You, it's a very, as a biology related student, I was never much into too much math. So I was going to medicine, and then, but I liked math when I was in school, and some of this basic concept come back, but we have to keep learning, and the idea is to keep learning always. You mentioned black box. Black box. There's a good book, Black Box Thinking. That book comes uh, from the industry of aviation. So
Mhm.
every plane that has an accident, it goes on the news. They talk about that, they promote that, and we learn from that. We have a duty, that actually the industry has a duty to learn everything they can, and they look at the black box. Let's say,
Yeah.
oh, they found the black box after the crash, and from that black box they can get information so that they would understand what happened. And the philosophy is that there is no failure, is always a good opportunity to learn. So we should do the black box thinking in medicine all the time, but
Mhm.
sometimes we don't do that. We hide the failures, and that's something we should be keen on not doing. And black box, the metaphor I use is something we don't understand completely, and then we have the data from there. But black box thinking is a different aspect. Just to highlight this, that came into my mind.
Yeah. So I think the second part we totally covered, and the third part is about the violet June.
Maybe it's worth to tell you the story why I was interested about keratoconus in the first place.
Yes, please.
So I was a first year resident, 1997, and I was with a group of colleagues at the clinic, at the private clinic of my professor, Dr. Sivental in São Paulo. And I have done a topography in my colleague, and everything was green, and he was with good vision. And then I was the one to be sit as a patient so that he was going to learn how to do a topography. And then he
Mhm.
was doing it many times, and he called it tending. And then she said, Renato, do you have anybody in your family that had a transplant? And I said, no. What you're seeing there? Oh, because you have a little keratoconus. So I was
Oh,
diagnosed with keratoconus when I was a first year resident. But I am uncorrected 2015 plus, uncorrected, both
wow.
eyes. And I had a little hyperopia when I was a kid, and I had an aggravating factor, which is mother and father ophthalmologist. So it's, at least we call, this is a risk factor for anything. But I have a good vision, and but I have inferior stiffening. So I saw my topography. It was the ISIS placidodis topography that time, and we used the blue to red scale with 0.25 and zero point 0.5 diopters interval. It's a normative scale, and if you change the scale, you can change completely what you see. And I had uh, an interest to learn what is topography. So it was 1997, and 1 year later, if I recall well, Yaron Rabinovitz published the Survey of Ophthalmology, Keratoconus. It's like a comprehensive, like a great comprehensive. And I got that copy of that paper in in my my floor. I was reading that every day, and I was learning. So, and I was never considering that one day I would meet Jan Rabinovitz in person, and I was going to publish papers with him. But my interest in keratoconus is because I was once diagnosed with keratoconus. And if you ask me what I have today, I have a stable inferior stiffening. I am now presbyopic, and I always thought that my inferior stiffening would give me like a multifocal cornea, but it's not so much for me to, because I have a little hyperopic refractive error. And my question is, should I do LASIK or not? I do believe presbyopic approach for LASIK can help patients like me if I understand what is going to be my blended vision approach, and eventually Dan Reinstein or other colleagues would be, I would trust them my eyes. But what I think is that if I have a cornea that can be weakened by a LASIK procedure, or if I would just do a surface ablation, but My understanding is that I have inferior stiffening with a little epithelial thick. It's not a perfect example, but eventually my inferior stiffening is much more epithelium than the biomechanics. But if you want to
Oh,
put
okay.
more complexity on this, I had from my father's side of the family, Gute and Keratoconus family members. So, and that can be just a coincidence, but my understanding of keratoconus started from a personal need to learn what I had because uh, and keratoconus in the cornea clinic, we only receive the patients with very advanced keratoconus for a transplant. And I said, there's a huge spectrum of the disease. And we learned that in medical school. We have diabetes. We have patients that are doing, they're athletes and they have diabetes. And we have the very severe diabetes with problems in the foot and all the vascular peripheral problems. And the spectrum of the disease, we understand that since medical school. But once you are in the situation that you see yourself as a patient, is I create a lot of empathy. And when people ask me about cross linking, if they need cross linking or not, I put myself in their shoes because probably if I was going to a private clinic with that inferior stiffening with 2015 and I was 23 years old that time, and they would say you should do cross linking because you have keratoconus. And I'm sure that a patient like that would not benefit from cross linking
Hmm.
because and my story just tell you I never did crossing, but I also learned that I could not rub my eye, and so the the Violet June campaign is to promote awareness about the disease because we have to teach patients in the best way as possible so they can live better with the disease. And you mentioned prima nocere, which is Hippocrates' foundation of medicine. And there's another one that I love, which is you you cure very few times, you heal very often, but you have always to comfort the patient. And it's challenging because you are human too, and you have your own things and you have to be really empathic on telling people about what they should, what they shouldn't do, what they need to do. And sometimes people get confused with these words. Oh, this doctor is very confusing. It's not confusing. You are progressing or you have bad vision. If you have one of these two, you need surgery. And the surgery, you have to understand, are you doing surgery just to halt the progression or you're doing surgery to improve vision? And we have different options. We have cross linking plus, you have rings, you have fake IOLs, you have cornea ablations that can be done without the cross linking procedure. Some colleagues are doing CK, and we now have the great work by Susan Jacobs and also by Elatex with implantation of corneal tissue instead of
Yeah.
a plastic ring. And
Okay.
all of these procedures, they would benefit patients with keratoconus. But as you said, we need individualized approaches. And the
Yeah.
individualized approach starts by anamnesis, asking patients how you're doing, and doing the best imaging that you have. You don't need to have all the fancy equipment because we can see that it's very expensive. But I would say you need imaging technologies, you need topography and some type of pachymetric map from Scheinflug and or OCT. And OCTs are getting better and better. Biomechanics is a plus. Wavefront devices for the whole eye understanding is a plus. Axial length is simple. Every cataract clinic has an axial length measurement device. Measure the axial length of everyone. Because if the patient has increasing myopia, see the axial length. If the axial length is elongating, that's the answer. Or
Hmm.
you can have a corneal myopization, or you can have a lens myopization. And all this data should be integrated in your brain so that you can
Yeah.
get a clinical decision. And each of these technologies may have some artificial intelligence to help you with your decision making. So I think the medicine, as I told you, I'm a son of father and mother of both of them ophthalmologists, and I have two little girls. And if you ask me what I wish to wish them to be a doctor And it means two things. First, I will be alive, that, and I'll have energy to help them for becoming an ophthalmologist. Second, second is two parts, is in the future ophthalmology will be a good business for them to work on, because the world is changing so rapidly. We don't know what's going to happen with medicine, with all the professions, with all this
Yeah.
technology. Future AI is part of that, and as I told you, AI is going to make the doctors even more relevant, but I may be wrong. They just come with a
Yeah.
perfect robot that can do everything. And so
Can diagnose
becoming,
the dermatological diseases, for example. This I heard too.
yeah, but you still need to be a doctor to use that data to help the patient. But we don't know
Absolutely.
what's going to happen in the future. And we also have another situation about the marketing, the how the
Hmm.
business of medicine is going to be. You have a nice private clinic because you can profit from that. And in the future, big organizations are going to take over everything. So it may be a good philosophy, a good life to be a doctor or not. It's great to be a doctor because you can help patients, and but not only this, they would need to like it. So if you ask, I wish them to be a doctor, it makes everything. I will be health and alive to help them. Medicine will be still good as a good profession, and they will have the willing to do it. And if they are going to do it, I imagine about the medicine they will practice, it would be very much individualized. It would be very much technological. They would, and if they have the basics, they will make a difference. Even today, we have a lot of technologies, but if you understand the basics, I remember, for example, when I receive a placido disc, I have a photokeratoscope they gave me, and learning how to use it, just to understand about the shape of the cornea and seeing how it, if the patient moves the eye, you see a different shape reflex. You learn that this is going to be critical for the patient to look perfectly in the center of the placido disc so that the topography will be fine. If you have a slit lamp and you have a slit lamp, and the slit lamp, if you angle it properly, you can have a foci in the cornea and in the lens.
Yeah.
So that's
Hmm.
the Steinflug angle that you're looking through. And eventually
Hmm.
having, and just how you measure the IOP if you don't have a good tonometer. If you are in the bed, you just touch the eye. And
Yeah.
the digital sensation, you can see if the eye is soft or not. If you have this, eventually that skill, that basic skill, can be implemented with the new devices, the new technology that will ever come, and then you can get to be a doing a better work, a better job for the patient.
And about the Violet June, I want to also to congratulate you with the project, because besides of the purpose, which is already amazing, it sounds also very beautiful. Violet June. I read the article why you named it Violet June, but can you also talk about that a bit?
Yeah, violet is a powerful light. I see
Yeah.
some violet in the back of you have a beautiful,
Yeah, this is my favorite color. That's
yeah.
why.
Violet is a very powerful. It has a lot of healing uh, meanings. But the idea of putting in June, it was just the middle of the year. We wanted to be May, and then May was not so approachable, and then, oh, let's do it in June because we wanted to do it. It was just like something that was, we needed to do it. And the Violet June is a campaign that is not from me, from Brazil. And I remember a lot of people asking me, should you do a campaign to promote yourself? I say, this is not to promote myself at all. And I was very happy when two guys, one from India, the other from Argentina, they talked to me about the Violet June campaign. Renato, if you like Keratconus, you should look at this campaign. I don't know if you saw that, but they are talking about Violet June to talk about how to explain about this keratoconus for the patients. And I said, "Oh, you like it? Yes, I saw it, but you should adhere to this." And they were talking to me without knowing that I started that, both. And I would say now I think I kind of accomplished my goal, but is even not scratching the surface because a lot of people still do not know about keratoconus. They still do not know that eye rubbing is bad for you. And I agree, we should join forces. Like the concept from Gatinel, that eye rubbing is really bad, and he has a beautiful video on the MRI machines, and that what happened to the eye when you rub the eye is really gross. It's really impactful. But the idea is to help people to learning, because the misinformation makes the patient suffer
Mhm.
more, and the family suffers even more. You suffer with fear. The best medicine for fear is knowledge.
Agree. Do you have website of Violet June, or is it just now on
Yes,
the
we have.
campaign,
Yes,
campaign and brochure?
we have a website. It's violetjune.com.br. It's still in Portuguese.
Mhm.
We use the hashtag violetjune4kc. So everybody that wants to promote, use that hashtag because it creates impact. I'm not a big marketing social media guy, and actually I go around this, but I never focus on this because I, I I always debate with, I'm not going to promote myself. I want to promote the idea. And even
Mhm.
if my private clinic, I sometimes lose a lot of opportunity to promote this because the way you communicate with people, some colleagues, they are very skillful for, and they are open to explain about that and to connect with people with little dances and things. I'm not like this, but I think we should be everyone should find a niche on how to communicate. And the way I try to communicate is to explain. And sometimes when I'm explaining to you, I'm thinking, so am I clear enough? Am I uh,
Totally.
totally clear to
Totally
explain what I
clear.
think? Because uh, and
Yes.
and the Valley June today is creating two studies. We have like a study for the incidence of keratoconus in our population. So we have a, a master thesis that I'm helping on at the university where I teach here in Rio. We have like 2,500 people at the the those are students, professors, medical employees from all sources, nurses, and all these people should be examined by Pentacam and Corvus, and then we ask them first, do you have keratoconus or not? If they have keratoconus, they will be separated. But if they don't have keratoconus, they will be screened. And this screening we already found a couple of people with keratoconus. So we have now 150 people already examined, and we have maybe 4 people with mild keratoconus. And
Wow.
and I would say my bet is to have about 4 to 5% of people with mild disease. That's what Emilio Torres and our colleagues
Mhm.
published in the BJO from a study that they put a pentacam in Hayat in Saudi Arabia in a pediatric hospital, not ophthalmology hospital, pediatric hospital. So they screened a 500 kids. I think it was the 500 kids, and they found 5% of the kids to have mild keratoconus based on tomography.
Crazy.
So
Yeah.
we need to screen that. We need, the prevention is better, is the best way. You prevent visual loss. You prevent people to get sick. You prevent people to suffer. So early diagnosis with proper education is key, and that should be turned into a global campaign. Actually, we are in Brazil, and we hope that to sensitize the government and the public health, because in Brazil, public health should be perfect, because the constitution in Brazil says that every Brazilian has the right for health care, and we we have this concept. This is not the same in other places, but we should sensitize people to have this type of campaigns to prevent visual loss, because keratoconus is very common, and refractive surgery has helped us treat patients with keratoconus. But the paradox is that refractive surgery also causes ectasia progression.
Mhm.
So that's why we need to use the technology to learn when and how to do the procedure in the safest way as possible. But if you want to have, it is a very interesting concept with artificial intelligence and math for risk calculation. If you want to have risk of zero, this is impossible, because the
Mhm.
risk is in the denominator. The risk you accept can be 0.000000001,
Yeah.
one in thousands, tens of thousands. But if you want zero, if you divide any number by zero is infinity. It's an impossible math equation. So there is no zero risk mathematically, and
Mhm.
that's very important to understand.
Well, I believe that this is my opinion that if you create something like which you have already, basically a website of Violet June, and then create maybe the opportunity for membership, and then many doctors internationally would just get the membership, or also, I don't know, or advise patients to go to
Yeah.
violetjune.com to get themselves informed if you have a different if those member doctors could also put their videos and to talk about the keratoconus in their own language and to make it more accessible to
What
patients.
I
I don't
tell
know.
people, what works here in Brazil is like this. We have the Vale June as a concept. So some colleagues they use Vale June for getting attraction for TV, for the radio. So they give interviews about keratoconus, and this is
Mhm.
very powerful because, and even colleagues that they do practice here in Rio, so they kind of compete with same marketing for patients. They use Vale June here for promoting their work, and I applaud them. I think that's what we want. And
Yeah,
but we don't it's a non-profit organization. And
yeah.
the second nonprofit work is doing the consensus. We had a consensus in 2015 that was published on cornea. It's a very cited paper from the Cornea Journal. And my colleague and friend Jose Gomez from Sao Paulo, he is leading the second edition along with myself and Hafezi. And Vale June is going to sponsor that, and so that we can get this consensus. The consensus is very important. For example, we talked about contact lenses. Now I can tell my patients that by consensus, contact lenses do not halt the progression of ectasia. By consensus, if the patient has good vision with glasses, cosmetic use of contact lens should be careful. Is a consensus. So consensus is much more than an opinion. Of course, consensus is not the final word. Consensus is a group of experts that 66.666% plus one is not majority got to agree with that. And some majority consensus occur, like eye rubbing is bad for you. Some majority consensus occur, keratoconus is not an unilateral disease. There's no unilateral keratoconus, but
Hmm.
secondary ectasia can occur in any eye. So I think these concepts are very important, but we didn't have a consensus, for example, on what is form fruit keratoconus. Form fruit
Hmm.
keratoconus, Rabinovich would say is inferior stiffening with a good distance correct vision, but something it's abnormal in topography. Kleist would say that this is a cornea with a normal topography from a patient with a fellow eye with keratoconus. And I would say this is mild keratoconus, the one from Frust says, and the one that Kleist would say in the editorial in British Journal 2009, he would say that the asymmetric eyes would be form Frust. And I would say sometimes those are unilateral, but ectasia. And unilateral ectasia is something you can see, and many patients have unilateral ectasia. But that's the challenge for the TBI because we have 10% to 15% of patients that are not detected with abnormalities. And if you want to try to
Hmm.
catch up these cases, you start having a huge drop in specificity. So, uh, but when we improve the algorithm, we can improve either, both sensitivity and specificity. But understanding what you're asking is key. And just talking to you in this interview can get my mind to get some ideas on things we should eventually organize.
And I'm looking forward to make another interview maybe a few months later when you maybe have already new projects and new interesting ideas to
Yeah, I'd
share.
love to talk to you about custom
Me
refractive
too.
surgery. Custom refractive surgery is probably it's related to keratoconus as well, but we have to distinguish elective procedures
Hmm.
from therapeutic procedures. That's the key. And having
Hmm.
our whys and our purposes very well defined is going to be fundamental for success in any field of life.
Hmm. Thank you, first of all, for this definite and so, how to say that, precise definition. For example, when you say elective and therapeutic, therapeutical approach of customized refractive surgery, because by giving the definition, we can already understand the whole purpose of
Yeah.
the procedure, and it's very important.
Words are powerful. We have to be careful on definitions. And
Absolutely.
elective and emergency, because when there are all ways people say, if you have a appendicitis, this is an emergency, so it's not an elective surgery. So elective surgery is something you can opt to do or not to do, but elective
Mhm.
procedures can be therapeutic procedures. So when you do cross-linking, is an elective, it's not an urgent procedure. But when I say elective, is something optional. And I don't like cosmetic, because cosmetic in some languages can be considered like for beauty, for like a plastic surgery for beauty. But even plastic surgery have therapeutic and cosmetic surgery. So, but the words cosmetic in English, it's almost perfectly fit here, because cosmetic is meaning elective, not necessarily for beauty.
True.
But
Thank you so much.
my pleasure,
Thank you
my
so
pleasure.
much. Really, I I can talk to you and listen to you forever, but it is Saturday. I don't want to keep you more.
I think your work is really good, because you try to put scientific knowledge, you try to distill the information about basic
Thank
science
you.
and
Yeah,
all this work. And congratulations for this
thank you.
stamina for keeping this type of work. And I wish you the
Thank you so
best.
much.